Welcome back, everyone. Happy Friday. And today our main agenda item is we have some visitors from the Vermont Department of Health, Dr. Fedrizi and Lyrica, who's an epidemiologist. And they have a few slides to go through, and then we're hoping we can have a discussion about some of the questions that they are interested in using data to gain insights into. So yeah, thank you so much for joining us. And we're really excited to hear about what you're thinking about.
Yeah, so is it okay if we start?
Yeah.
Yeah, so I'll let Lyrica introduce herself when it's her turn in the presentation. We just have a handful of slides just to orient you to how we're thinking. Some of these concepts may be concepts you've already investigated a bit, knowing that this project was coming. So my name is Rudy Fedrizi. I'm actually an obstetrician by training and did that for about 17 years. But about a dozen years ago, I got into population and public health, and I've been doing that kind of work in a non-clinical way ever since. And for the past 3 years, I've been in the White River Junction office of the Department of Health in Vermont. The way Department of Health in Vermont is structured, very different than New Hampshire, is it's in individual district offices. So there's 12 districts, each of them directed by someone like me, and each of them having a staff of about a dozen people. And those dozen people do the gamut of public health. And those are things like emergency preparedness, immunization, workplace and school wellness, substance misuse prevention, food safety, WIC, the Food for Young Families program, maternal child health, and supporting children who are brought into care by the state, like foster care children and things like this. So it's a pretty exciting work, and now more than ever, public health is in the public eye because of the pandemic. So the next slide. So this project in particular, we're trying to dig into the whole concept of equity. And I have to apologize. I'm going to go back and forth from equity to inequity to disparity, because even in my mind, I'm not sure the best way to describe it. And your class being a class of storytelling and trying to figure out how can you create a compelling narrative that will help people understand and also be emotionally drawn into the issue is really important. And there's different ways of thinking. Some people believe we should always play strengths. We should talk about equity and resilience. And other people say that doesn't draw people emotionally. We should talk about the difficulties and barriers. And so even I'm a little unclear about that, but I thought we'd just throw up 3 terms. The whole concept of health equity, that everyone should have this just opportunity to gain the highest level of good health that they're have the capacity for, and that in order to do that, we have to remove all those systemic barriers that get in the way. Unfortunately, I think Americans in particular think of health as an individual choice, and we know that individual choice has a pretty small impact on health, and it's really all those other social influences, you'll hear them called the social determinants of health, that really impact health. Health inequities, when we talk about inequities, we're actually talking about differences in health that don't need to be. They're avoidable, they're unjust, they're created by the system and that we've created, and they're really reversible. When we talk about disparity, we really mean differences, whether they're unjust or whether they just are. And obviously as an obstetrician, there were illnesses and conditions I saw that were particular to women. And so there are disparities between men and women that aren't unjust, they're just anatomical sometimes. And so that would be a disparity where, for instance, if you looked at a graph by gender of number of births in America, you'd see that most of them are women and very few are men. And there's a disparity, but it's not one that's an inequity. Next slide. So one model that I really was drawn to, and it came out shortly after my medical training. I was trained in the late 80s, was this Dahlgren and Whitehead model. And Dr. Dahlgren is still around, and she's still publishing in this field. But it was and you'll hear this called this rainbow, social determinants rainbow. And it just shows you that there's many factors that influence health. And something I wasn't taught in medical school was that healthcare or medical care itself is only about 10%, maybe 15% of your overall health. And yet, in America anyway, we spend something like 95 cents out of every dollar on medical care. So we spend something like 95 cents out of every dollar on medical care. We spend about 5 cents out of every dollar on other types of health, like public health. And we wonder why we don't have great health in the country and why we're always, 30th on infant mortality and 30th on maternal mortality and other things. It's because we tend to invest in rescue and we don't invest in upstream prevention. So this Dahlgren model is pretty helpful because it gets at maybe the root causes of inequity and reminds us that healthcare is just a minor element of your health. It's really what motivated me to get out of medicine. I think when I went into medicine, I assumed I'm going to help people, I'm going to make people well. And I realized pretty quickly, all I do is carry a pager and rescue people when they're in ill health. I do very little that promotes health. And then when I jumped out of clinical medicine, it was very easy for me because I now feel like I'm improving the health of a whole community rather than rescuing that person in front of me who had some crisis, often a crisis that was preventable. So next slide. So one resource I would ask you to take a peek at before you start our project is this frameworks webinar. In the blue underneath is the actual, you can have these slides, but the blue underneath is the actual URL. And what Frameworks did is they surveyed the country around the question of health equity. And what they learned was that most Americans don't get that there are social factors that influence health. They think health is someone chooses to smoke, someone chooses to eat poorly or doesn't exercise, and don't really see that your choices are often a reflection of your income or your education or your geography, where you live, the influences you have of the people, your peers and people around you, your family. Most of them think it's just bad health behavior of someone who doesn't do the right thing. That's one thing. The second thing is a lot of people hear the word equity, and the only other time they've ever heard it is when they hear there might be some value in their house that they've owned for a lot of years. They might have equity in their house. They have no idea that equity has anything to do with fair and just health. So that's two things that this Frameworks webinar describes from the survey work. The other thing they think they've discovered are some best practices when you do communicate about equity. They think that Americans in particular love the idea of fairness and justice. So if you can talk about gaining better health as Americans is the fair and just thing to do, that will carry some weight. It's better to explain how disparities came about rather than pick on the population that has a disparity. They find that the second you describe a certain population, and I'm just making an example of people of color tend to have this health condition more than those who are white, instantly what people hear by that is, this is a problem of people of color, not my problem if I'm white, so I can forget about it and I have no role to play in it. Rather than say, because we've failed in keeping pace with middle-class incomes, people have less money to buy the basic necessities for well-being, like decent food and decent shelter and all of these things. And because of that, certain subgroups now struggle because they can't even afford the basics that provide you a foundation of health. That will go a lot farther because people hearing that, oh my gosh, we got to think about raising wages. We've got to think about why this country hasn't kept up to support the middle class, rather than focus on the population that's impacted. For instance, they want you to throw out that solutions exist and it's possible. So you don't want to make it sound so impossible. In other words, frame it as, hey, for the past 200 years, we haven't moved the bar at all on, XYZ. That sounds like we ain't going to move it this year either because we haven't gotten it right in 200 years. So why are we going to get it right this year? Versus being really inspirational, aspirational, as this is something we can tackle. There are communities in America that have already tackled it. And it's just our turn to tackle it now that we've identified this as a problem locally. So these are just some of the best practices they describe in that frameworks, but it's an excellent webinar. Next slide. So the other thing is we're really hoping that as you dig into the data, you also think about how do we not just describe or tell the story of what you're finding, but how do you display it in a way that's kind of instantly understandable and recognizable? And again, if you don't get to this, so be it. But boy, this is something that we don't do well. We do a great job of giving population averages. You want to know what the percent of people with diabetes in Vermont is? It's 9%. If you want to know what the percent of adults with hypertension is in Vermont, it's 27%. But we don't do a good job of saying, does each of us have that risk of developing diabetes or hypertension? Or are some subgroups more vulnerable and susceptible to that than others? And so the Institute for Healthcare Improvement created a white paper called Achieving Health Equity, a guide for healthcare organizations. Obviously, they're a healthcare advocacy organization, so they're going to focus on healthcare, but I think it's pertinent to any kind of discussion of equity. Here are some of their bullet points of what they thought might work. They felt like you got to have a reference point. You have to have some average. So you got to state that the chance of diabetes, the percentage of diabetes in Vermont is around 9%. So you need some benchmark, but then from that benchmark, you need to figure some way to show different subgroup stratification. And they talk about absolute and relative terms. So the graph to the left, you'll see, it gives each subgroup's risk of mortality. And you can see that, for blacks or whites or males and females, numbers are given. So absolute numbers are given. But then in the same graph, they show the relative, that it's as you might imagine, it's mortality rate for men and women may be different, or for different genders, different racial groups may be different. So showing both the relative differences as well as absolute numbers are important. They think you should describe health when you're talking about health inequity by calling out the inequity. So you don't want to say, hey, 70% of white women get mammograms and 65% of women of color get mammograms. That's not as compelling as to say 30% of the white population don't, but 35% of the black population don't. There's that discrepancy. So you call out the discrepancy in data measures of inequity. So anyway, this gives you some ideas, and we're game to sort of explore this. And if you find other frameworks for describing data, that would be awesome. This is just one that came to mind because we've seen it recently. I think this is my last slide, one more, and then Lyrica can introduce herself and talk about her slide. So about 2 months ago, we decided to take a shot at a data disparity dashboard. And the reason we're doing this is because every state this year got a large grant from the CDC called the CDC Reducing Health Disparities Grant. So Vermont got around $28 million to spend. And so even at my district level, we're soon to spend some of those dollars on trying to really combat inequity. So we thought, well, let's take a peek and see what we can find quickly about some disparities in our region. Now, this is not anything other than a draft example. I don't know that any of these measures will stick or any of them will really be compelling. But what we did, you'll see at the very top, it talks about guiding criteria. If and when you guys dig into some data and decide you're going to pull out some disparities you uncover and describe them, I would ask that you at least think of these guiding criteria, because I think it helps my work to take what you find and then operationalize it locally. And these are 4 things. And these 4 things are, I like if they're aligned to social factors. So if you can call out disparities and say, hey, this disparity is linked to housing, this one to income, this one to safety, this one to that will help keep everything making sense to people who have seen the social determinants model. It would be nice if what you find we can compare to other either districts or counties or states, so that we can sort of compare against some other peer group. So all of these measures we could find at the county level, the state level, and the national level. That was why these measures were important to us. We wanted to find measures where my own county, which is Windsor County here on the Vermont side, but it could be Grafton County where you all are. We wanted to know where they were doing poorly. So I didn't need to call out a measure where we were doing sort of well, no, not a lot better, not worse than others. These are measures where we underperform Vermont. So as a county, there are 14 counties in Vermont. These measures put us in the bottom 6 counties in Vermont. So we wanted that to be another threshold for us to meet that thing. And then lastly, it would be great if whatever you uncover isn't impossible to imagine that we could create solutions that might move the needle. You might be able to find that for whatever reason, cancer death rates for esophageal cancer in my county or Grafton County are astronomically high. Nothing you or me are going to do in the coming years is likely to move the outcomes on esophageal cancer. Those problems may be related to treatment choices. It may be related to longstanding, decades-long behaviors of the patients that have those conditions. Yet there may be a tremendous disparity between folks in our region and folks in other regions. And those disparities are important to call out. And there's probably groups that would be interested in trying to figure out what that means and why would our population be succumbing to things like that at a different rate than other populations. It's just that for my work, none of that's very actionable. So I would ask that you find things that are actionable. So Lyric, why don't you introduce yourself, show your last slides and tell your story, and then we can open up for questions.
Okay, sounds good. Thank you, Rudy. So my background is I have a master's of public health and health promotion and health behavior, but I also have some experience in infectious disease epidemiology. And I'm currently working as an epidemiologist in our COVID-19 response team, which we call our HOPPER team, so Healthcare Outbreak Prevention and Response. So we respond to outbreaks and cases at long-term care facilities, shelters, and Department of Corrections. So I'm really immersed in the COVID world and been thinking a lot about health disparities in terms of COVID. So wanted to share a couple of examples of where that is right now. So just switching gears slightly from looking at more of like the chronic disease and thinking about like population health promotion, thinking about to infectious diseases. So I came across this on our Vermont dashboard. So this is just from our surveillance that we do. And this is kind of an example of when you're looking for data, it's really important that you pick data that is going to demonstrate where the disparity actually is. So if you look at the weekly case counts by race, you can see that we've had a pretty big surge in the past couple of months. You can see that the white population, non-Hispanic, is in gray, and the Black, Indigenous, and people of color is green. And if you look at that, it seems like, okay, like that could make sense based on what we know about the population in Vermont. But then if you look at the weekly cases by rate, so per 100,000, you can see that the rates pretty much mirrored each other throughout the pandemic until this Omicron surge. And then it's looking like the BIPOC population is experiencing a rate of about 3 times that of the white population. And so this is a good place where we can say, like, what's going on here? What are the social determinants of health that are underlying this? What health access needs to be improved? So just using this data to better understand what the story is and how we can create actionable solutions to mediate that. So I was just kind of opening this up to you all. So thinking about what Rudy said in terms of looking at those different frameworks, is there anything that like stands out to you that could explain this difference in rates that we're seeing just in the past couple of months?
Cool. So lots of really interesting stuff here. First of all, thank you both so much for those interesting slides. So I had some questions, and then maybe the students can kind of bootstrap off these, or if there are other things that you wanted to bring up or notice. So one kind of broad question for you, Rudy, is you mentioned like you're looking for actionable kind of items or insights. I'm trying to like wrap my head around how to think about that concretely, and like how can I know, or how can we know what knobs we have to work with here and what might be actionable? Like if we find some drinking water issue, is that actionable? Or a housing issue, is that actionable? Or like, weather patterns we presumably can't do anything about. How do you think about that?
So two things that I would turn you towards, and one of them is that the Public Health Council of the Upper Valley, which on the New Hampshire side is sort of like the health district that I run here on my side. Not exactly right. New Hampshire has a very marginal public health infrastructure because of its tax base and not having any state money. So there aren't the equivalent. I grew up in New York State, where every county in New York State has a county health department. There's no such thing in New Hampshire. So very different. But one thing is the Public Health Council of the Upper Valley has a community health improvement plan. Every 3 years, they note a plan. Now, whether those suggestions and strategies are actually actively being undertaken is in question, because it's all a question of resources and how much the COVID pandemic has disrupted what was intended. But that's one resource. If you looked at the Public Health Council of the Upper Valley's Community Health Improvement Plan that is in its last year, because we're going to do a brand new one this year for another 3 years. They're every 3 years. That would be one source that could tell you, okay, I get it. There's things that were imagined in the Upper Valley to do to impact the health challenges that were felt to be core, and here they are. And the other one I would say is go to the Vermont State Health Improvement Plan. That's a 5-year plan that is, I think, coming up in 2025. So it's in the middle. And again, these are very, very, very disrupted by COVID. I mean, Lyrica and I have done, well, Lyrica is an epidemiologist who's done no epidemiology except for COVID. And she should be doing every other disease you can imagine out there that you don't want to catch. And I've really given up a lot of my workplace wellness work. And you'll even see the huge increase in the burden of opioid-related deaths in this COVID period of time, because I think our prevention work has been stymied by COVID. But the Vermont State Health Improvement Plan is another document that lists 100 different strategies in different categories of prioritization. And that would be another place you would say, I don't know exactly what they're doing, but I get that they want to, improve youth access to reproductive health services in the school, or I get that they're imagining bringing more health services into the school, or behavioral health, mental health into the school. So if I uncover something about mental health, I can be sure that there's someone working on increasing access to mental health services in youth in the school setting, let's say. Those would be two places I would say you could go and be comfortable to know that someone was thinking that those solutions might be worth pursuing, whether we're actually pursuing them or not.
Okay, so something about like maybe tweaking or evaluating the kind of existing proposals. Okay, that's really helpful. My other question, let me go back to this slide. So I did some digging through the data sets that you shared, and it looks like the kind of bulk of the data have the form of like, what are the rates or counts of various, factors maybe along these lines in, by county or region, et cetera, or statewide. Some of them are broken down by time. So that's all really interesting. But then they're not all, like, we don't have all the factors for all of the things. So like we don't have education and housing information, say, for the same subgroups of people necessarily. I guess we could break it down by county, but do you, well, I guess either Rudy or Lyrica,
So-
how
so-
do you think about these things? And
Yep.
how do
So
you,
you're bringing up the whole idea of intersectionality. I gotta be careful, it's an OB doc. Intersectionality, this idea that we're not just white or black, male or female, but we might be white and high school educated and in a low paying job. And what does that population look like compared to one that's different than that, and things like that. So the best source for that, honestly, up until COVID was, and I would turn your students to this. And although we would love timely data, we would love it to be timely. You'll see even these measures are they come from the 2021 American Health Rankings or County Health Rankings. They're all 2018 data. They're 3 years old already at the best. So the behavioral risk factors survey that the CDC does, we call it BRFSS, BRFSS. That data source is the country's best data source. It's been run for decades. It's a phone survey of the CDC. It surveys every state, every county. It does it in a statistically meaningful way. And it captures demographics so that you can stratify a health outcome by people of higher or lower educational attainment, or people who have different levels of income, or people who are housing or secure or insecure. There's things like that. So the trouble is that after about 2018, New Hampshire, who had a really good system, you could do this yourself by going online, played with that system, and they created something called New Hampshire Wisdom. And that's another source I would say take a peek at. I don't know how timely that data is. I don't need you all to find data in Vermont. If you have a better New Hampshire source that will allow you that granularity to say, hey, in the Upper Valley, we're seeing incredible disparities in certain behaviors or exposures depending on income or educational attainment or what have you. So that BRFSS and New Hampshire Wisdom is maybe the best we're going to do in New Hampshire. We have the equivalent in Vermont, but Vermont doesn't allow you to manipulate the data yourself. It instead feeds you data briefs that have been done at the state. So I don't know when the most recent one was, but I'm sure it's a couple years old. But you could go to that, and there's where you would see some differentiation of subgroups, and sometimes men versus women with low educational attainment, let's say, and that would be a much different thing than simply men and women alone or something like that. So I'm also, honestly, I know this project is for you all to uncover some disparities and sort of create a story about what they mean and what we could do about them or things. But I'm also happy if you all stumble on, hey, we found a source that's actually more timely than 2018 and it's reasonable. Or we found out that maybe the census data that's put out, or the American Community Surveys around consumer behavior have some health related topics that we think are valuable. Gosh, if you just discover other data sources, in a sense, this data dashboard is really a disparity across counties, right? How are we doing compared to Grafton, compared to Sullivan, compared to Orange? It's not really within these measures, how are some people doing better or worse than another population of people? And that's what we really want to get to, obviously, as granular as possible. But Lyrica, if you know other things, please share.
The only thing I was going to add to that is with the BRFSS data. I don't know if you know about this, but there's a really good tool. I don't know if it's like WEAT, where you can do cross tabulation just like with the data set on the CDC website. I haven't played around with it for a while, so I don't know exactly what it gets down to in terms of location, but I think you could compare Vermont and New Hampshire. You could compare Vermont to like aggregate US data, or New Hampshire to US data, but I don't think that it has county level data.
And then prior to COVID, every state has a CDC paid BRFSS coordinator. And that person could often be an incredible resource. If you really said, look, we're doing a project on, diabetes and hypertension, and we want to get as accurate, as timely, as detailed down to the county level we can, that individual often could pull a subset of raw data for that. It's just that, at least in Vermont, I'm sure in New Hampshire, those folks have been pulled out of that work and are now doing COVID-related data to create tables like you saw the graph that Lyrica shared. And those people just aren't available to us right now at this moment. So, yeah.
Got it. Okay, yeah, that's helpful. So maybe we can open it up to the class. I thought we could maybe do like a brainstorming session. Like, are there particular questions that you're excited about, or types of disparities you would want to understand better or look into? Some type of data that you're wanting to understand better? Do you have questions about, what are your thoughts? Yes, Allison, sorry, I didn't see your hand raised there.
Oh, it's all good. Thanks for your time and for coming to speak with us. I had a few questions. My first question is I think it's my understanding we're making videos or data visualizations. To make it the most helpful for you, who is the intended audience? And like, how should we be tailoring that?
Yeah, that's an excellent question. I really appreciate that question. Most of my work, well, first of all, just to know, though Vermont has 10 times the public health infrastructure as New Hampshire, which is remarkable. I've worked in both states, so I know. I have zero budget. I don't have a dime. I can't invite you over for breakfast and pay for it here. So that shows you that even with all the resources Vermont has at my level, all of my influence, it occurs at the organizational partner level. So typically we're trying to move a group of organizational partners to take on a certain problem or understand a certain problem or believe there's a solution to a certain problem. So the best audience for me would be anything you all do, we would share at one of three tables, either that Public Health Council of the Upper Valley. It's about 40 organizations. They're all are trying to improve the health of the area. And you might just look at their website, see their mission. I'm actually their board president, and get an idea of what that group is, who's in that group, because that would be one venue where we would share what you do. The second one is a group called the Greater Upper Valley Integrated Services Team. It's a very similar organization. It's just on the Vermont side. And it's a group of about 40 organizations again. But this group is a little more oriented towards delivering services. So that's why it's got its service title. And so this is folks that actually care for people. It might be the Division of Child and Protective Services might sit at the Integrated Services Team meeting, where they may not just sit at the General Public Health Council table. So that's it. The third group is every hospital in Vermont, most every hospital in Vermont has a community health improvement team. And in my district, that's the Windsor Health Services, it's called the Windsor Community Collaborative. It's another group you might look into and look at their website, because they're very action oriented around 6 different priorities, and you'd see the kinds of actions that are happening. So that's called the Windsor Health Services Area Community Collaborative. It's got a terrible name. There's the equivalent happening at the Gifford Hospital, which is in Randolph, Vermont. That's called the Randolph Executive Community Collaborative. And then there's one in Bradford, Vermont, which is called the Upper Valley Unified Community Collaborative. And all 3 of those tables are other coalitions, all anchored in health institutions, but other places where people come together wanting to understand what the needs of the community are and how we can meet them. So to long answer to your question, this is not to go down to the level of the person who might be experiencing trouble with lead exposure. It would be one level up from that to the organizations that might be able to impact why those families are exposed to lead and therefore lead is seen as a huge, I put lead on my dashboard, you'll notice, because we do pretty poorly around lead here in the Upper Valley. Our homes are old and they're sometimes poorly cared for, and many of them are rented. So there's lots of turnovers, there's lots of young families, there's lots of kids that will chew on lead paint versus old, beautiful homes that are owned by, one family who doesn't do those things, for instance. So I think that's one reason why the Upper Valley struggles with older homes, where if you lived in, Cambridge, Mass, or, in Rhode Island, old homes aren't as dangerous in those settings because of the way they're used,
Yeah, that's really helpful. Thank you. And then going off that question, in terms of either public funding or public interest, whether in the news, have there been certain issues outside of COVID that have been more highlighted? In other words, if we focus on issues that already have a lot of public backing, I don't know if that would be more effective, or if you want us to look for the more niche issues that are still very important.
Yeah, that's a great question. And again, I'm a little bit out of practice because COVID has so consumed the oxygen in the room. I would say that these are things I'm not good at because I never took a class in storytelling with data, but I imagine that there are things that capture people emotionally. And sometimes those are things that affect the youngest children. It's hard for us to swing senior or older adults' behavior. It's easier if we focus on their grandchildren and say, it's that kind of thing. So I think finding disparities that are impacting the youngest, most vulnerable children sometimes can carry a lot of emotion, and there's often it's easier for people to fund those things versus populations that are, again, with this American lens of health behaviors seem to be what people think influence your health. It's pretty hard for us to affect, adult smoking experiences. It's a lot easier for us to talk about middle school vaping, because that's seen as something that, those children need to be protected from, where 50-year-olds who smoke, that's like their problem, and how are we ever going to move that, and why would we spend any money on that? So I think youth has a little bit of that ability. And then I would say, if you can find something totally unexpected, you'd say, oh my goodness, we have great health in the Upper Valley, we have great educational attainment with major academic institutions, and yet, boom, this is something no one might have expected. That would be a cool thing to stumble on, something that your first inkling would be, how can that be here? That shouldn't be, or something. Like I heard you mention something about the purity of water. I think we think of this area as being, we live here because it's so beautiful and so idyllic. And if you found out that well water is poisonous here, that would be a pretty powerful story to say why you should have your well tested, because, as beautiful as we live and as clean as the air seems, the water you're drinking may not be so safe. I don't know, that's an example. In Vermont, we tested every single faucet a couple of years ago in every single school and every childcare setting, because it was believed that maybe lead was in the plumbing and fixtures of our schools and things. And sure enough, a huge number of faucets and plumbing piping had to be replaced in childcare in schools. That was an easy sell to talk about that. It would be a lot harder, I'll bet, if you said, hey, we should pay to have everyone's home tested for lead. Oh, all of a sudden people would start to say, what do you mean? I don't want to pay for his house. But it was easy for them to think of paying for schools and childcare mitigation. So those are just some ideas.
So your kind of sense is like people want to spend, if it's like community money, like public funds, you should spend it on public goods or public benefit rather than personal benefit. And then, there's that, whose fault is it when you make a decision? Kids, maybe it's not their fault, so you have to protect them. Adults, maybe it is their fault, so they pay the cost of their poor decisions or something like that.
There's another concept in equity that is you'll have more luck influencing policy if whatever your solution or your policy change that's suggested is going to benefit everyone, but going to be able to be targeted to those most at need first. So it's the belief now, there's been a lot of work around framing equity, and maybe this is even discussed in that webinar, but this idea that if I were to say, I'm thinking of creating a pilot program where I'm going to find all the faucets of immigrant children in the Upper Valley, and I'm going to do something about that. That will carry less likelihood of passage than if you said, we are going to test every home in the Upper Valley for lead in the drinking water that has a child under the age of 5. We're going to start with children who are new to America, and then we're going to march along on this phasing. That often will get funded because it's seen as benefiting everyone ultimately, but it's targeted initially, and it's got a funny name. It's called something like targeted universality. And it's like, it's okay to target first and then commit to doing everyone ultimately. It's a little less appealing in our current political environment to only target and think that's going to go and that's going to make its way. So that's just another concept you may stumble on in some of your reading and things.
Interesting. Yeah, what other, so Allison, since you've asked a few questions, we can certainly come back to, does anyone else have a comment you want to jump in with, or an idea you want to? All right, Allison.
Sorry, I'm known to ask a lot of questions. So my other question was, like, how do you want us to think about COVID in this? Do you want us to focus on COVID or try to avoid it? And generally, which issues are most important to you? Both.
Yeah, Lyric, I'm sorry, but I hope they don't pick COVID. We're looking, I think we're looking to change the narrative to a post-COVID narrative, or, a beyond COVID narrative. So if you can find non-COVID things, that would be good. I mean, COVID's uncovered a lot of inequity, and that's been really, it's one of its values is everyone now gets that, older adults are sometimes vulnerable, people of color are vulnerable. I would say some things, this disparity dashboard that we're seeing now, not that these individual measures are the right measures, or could even, as Jeremy said, we could even dig into them, because maybe we can't. But some of these topics like mental health seems to be a real hassle. So I would say mental health. Lead, I just mentioned, for some reason we do poorly with lead in this region. Anything to do when the subgroup might be a gender or sexual minority, we do really poorly in the Upper Valley. So I would say dig into that population, especially school, because there's a school database you can have access to called the YRBS, the Youth Risk Behavioral Survey. It's kind of like the BRFS in a way, but this is just for school-age children. And it has a wealth of information, and it's very detailed in terms of stratification. And you can even stratify by things like the youth's grades in school. And you can see that, children who have good academic achievement have a very different trajectory around their health than a child who tends to be a C or D student, let's say. And so that YRBS data set's a good one. So I would say, anything with youth, anything with mental health, lead, just because it keeps coming up. I think oral health and dental health is another thing where this Upper Valley has some of the worst statistics in the whole state. So that's another thing you might dig into. We don't seem to have enough dentists. You may even see that even though both New Hampshire and Vermont are some of the best insured states in the country, I mean, Vermont is always one of the 2 or 3 best insured states. There's this concept of underinsurance, which is like, just because you have Medicaid doesn't mean that's going to help you get access, because you may have Medicaid, that means you're insured, and God forbid you in a car accident tonight, you're going to get good care in a hospital, it's going to get paid for. But if you want to get dental care, very few dentists take Medicaid. So you're insured, but you don't have the right insurance, essentially. And that might be something worth digging into. So I think the whole idea of healthcare affordability is an interesting one. Or people who choose, I just saw a presentation today on people who are food insecure tend to also be people who trade food for medicine. So I got hypertension and diabetes. I don't have enough food. Today I'm hungry. I'm going to go without my medicine in order to eat. And that whole idea of food insecurity related and correlated to other problems with health, like poor compliance with medication, or is a kind of an interesting one as well. And then housing is terrible in the Upper Valley. You guys probably know that just being students here. I haven't been able to build a house I wanted to build on a piece of property in Vermont because I can't possibly afford it. And if I can't afford a house in Vermont, then I understand that the region's struggling. So the whole idea of housing, the fact that a high percentage of people take a high percentage of their income simply to have a roof over their head is a huge problem. So I think, this list is not a bad one. It may not be the right measures, but I think the themes that are called out in there are probably important themes. And as I say, if you go to the Public Health Council and look at their community health improvement plan, as well as that Windsor community health improvement plan, because they have one also, you'll start to get what the population, both of those, both the Public Health Council and the Windsor, have surveyed thousands of local residents, asking them what they think the hassles of their health are. And I have to say, that's another thing public health does poorly. And that is, do we ever ask the people who are most affected what they think they need or their problems are? So if you all can stumble on some literature about, the voice of those, what they call voice of those with lived experience, that would be a pretty important thing. Dartmouth is pretty famous for doing something called photo voice, where you give a camera to a person who's in a prioritized subgroup, and you say, you take pictures and you caption those pictures in ways that tell me some truth about your experience and how I can understand what you're up against. And that photo voice is people will take a picture of, their backyard, and it looks a certain way, and they're like, this is why I can't have people over. This is what, and therefore I'm isolated. This is why I constantly, struggle with my health. It's really powerful. So we do that poorly. So if you all can stumble on anything around that concept of voice, of lived experience, or look into that photo voice, which I say Dartmouth is pretty famous for, that'd be a cool thing.
That would be an effective storytelling tool also, I imagine. So yeah, very cool. Yeah, Fanwari.
Yeah, I have a question. Like, I know that because of COVID, some people with other like long-term disease, they could not get their treatment on time, especially at the beginning of the pandemic. I just wonder, would this kind of data be available to us, and where can we find it?
So just this month, I've been reading. There's some data. I don't know that we have that kind of access. Essentially, the excessive health morbidity of COVID. That sure, COVID itself has killed some people, but COVID also has delayed care or had people avoid care. And that in of itself has had a morbidity and mortality impact on folks. And there's some data that came out of Philadelphia to show that something like 20+% excessive deaths that can't be tied to COVID, but are occurring in the time of COVID, makes you think exactly what you just said, that people are either avoiding care or can't access care or are putting off care. For all those things. So I just don't know that kind of data sets or anything we have access to. I apologize to your teacher early in this process when I said there was a time when we had data analysts at the state who would have loved to be on this project and would have gotten you whatever, because again, these data exist around emergency room utilization, inpatient utilization. You all could could dig into data that would show that compared to 2 years ago, fewer people are coming in for different problems. And it's probably not because they've been cured. It's probably because they are no longer finding it easy to access those services. It's just that we don't have the access to those data sources anymore. So I'm sorry, unless there's some way that you uncover, because obviously I don't know what data sources Dartmouth Medical Center releases. For all I know, they release some information about trends of people, different care related trends over time, and from that you might draw some conclusions. I don't have access to that. The Dartmouth Institute, that's all they're about, really. So
Thank you.
yeah, I'm sorry about that. Jeremy, I know we were going to jump off at 3 just because it was our time. I don't want to take longer than your class is, but
yeah, sure. Yeah, well, I can continue the brainstorming and discussion. Thank you again so much for joining us, and yeah, and we'll be in touch with, I'm sure, some questions and hopefully some stories.
And we're happy to meet, at some regular, if you say, every 2 weeks you want us to bop in and see where you're at, we're happy to come online and do that. We also, at the very end of this presentation slide deck, is the ways you can email myself or Lyrica. And if you guys have some, ideas or something you want to run through me, feel free, if that's allowed by the way your class structure works. I'm happy. We don't expect the most timely response because often we're in vaccine clinics or something else, but we will commit to getting back with you and staying engaged with you through this process. So really appreciate it.
Very exciting. Thank you so much again. And yeah, take care.
Take care.
All right. So that's the Department of Health. So, well, I had a few thoughts. So they mentioned like a few possible directions. So one was like mental health, another was lead, another was gender and sexual minority in schools issues, another was youth in general, another was oral and dental health. So those are possible targets for like things to focus on. Does anyone? Yeah, Kareem.
I think it'd be interesting if we did mental health, considering how limited the research in the field is and how it's still developing.
Yeah, so something about mental health, that could be great. So yeah, we could look up statistics, we could look up mental health provider availability, cost. Maybe Frank and then Allison.
Just to build on what Kareem said, maybe mental health on different groups of people, different groups of age, mental health for minors, mental health for like college students, high school students, for minority groups, for groups with low incomes, for like homeless people, maybe for, I guess we can just combine like different groups to like together for the intersectionality, and that'll probably be something that have had little focus before.
Yeah, that's a good point. So digging into just one of these categories could involve other interactions with that category. So if we wanted to focus on mental health, presumably income, housing, like food security, education, available, like access to healthcare, etc., are all going to have an impact on mental health. So we could try to understand that better. And then we could look at like, well, equality or inequality or disparities in health across different groups, geographic regions. I guess that would be a group also, but yeah, etc. Yeah, that's a neat idea. Allison.
Yeah, so I just had like a couple of logistical questions. So like I've never been in a class with an SIP before. So I guess like what is like the expectation on their end? Like do we pay them for this? Or like the reason I'm kind of asking is like I don't know if we should pick a topic where like Dartmouth already has a pre-existing research infrastructure. So they said they have a lot of money. So if we pick something that's like Dartmouth already has a fund or does research in the space and we could like give money toward that, that would be helpful. Or if we look at the websites they were looking at, the committees they were talking about and pick one of those issues. I'm just trying to think of like what would be most useful for them.
Yeah, that's a great question. So the idea of the SIP program is like organizations in the mostly Upper Valley that like, so mostly nonprofits, but also some like government organizations like the Department of Health, who might not have funding to hire someone to like make a presentation on some topic. The idea is Dartmouth students can like, who are taking classes that are aligned with whatever the goals of the organization are, might be able to step in on that role. I think it varies, I don't know whether something we produce in this class is going to end up being useful, but it's an opportunity. And one of the requirements of this program is like, if the products we make in this class, if the stories we make for this particular project don't end up being useful, like it's not like that's going to have a negative outcome because they're like, it's not like public health will be negatively impacted because they're counting on us for this thing. And like, none of us have training in public health, and it's not like we're being counted on to solve some issue that the Department of Health isn't able to solve. It's like, but there's a chance that if we are successful at like making a story that uncovers some problem or makes people aware of some issue, it's an opportunity also to lead to change. And I'd imagine then people would, be inspired to look into it further or notice there's some problem that they might not have noticed before. But, our role for this class is like basically assignment 4. So it's like putting together one story, and each of you might decide to put together your own story, or another unique feature of assignment 4 is you can now work in groups from here on in the class. So the whole class could decide to put together one single story. You could divide into groups and teams. Each team could put together a story, etc. And then as we move on in the class, you can decide, okay, that happened, we're done. Now we want to focus on other questions. Or you could decide to like continue your own story, another group story, etc. So it's quite flexible. If something exciting happens and people are excited about some question or some topic, and then we wanted to continue it, it sounds like the Department of Health folks are happy to continue to engage with us, but that doesn't have to be how the class proceeds. So.
Gotcha, that makes sense. I think like I'm just coming more from like a policy standpoint, and like there are people in this class that like have connections with news organizations on campus. So that's kind of why I was asking, but that's very helpful background. So thanks.
Yeah, sure. Yeah, so there's no like, to answer your original question, there's no like specific funding that we have to like go start a research study. But so the like funding is like your time, basically, all of our time. Marie, yeah.
I just wonder, are we narrowing down like the topic to one specific, and do we have to do the topic, or I just wonder, does that mean like we will find like the same database and we are just using the same data to do different stories?
Well, so I think for the purposes of like assignment 4, I would recommend kind of narrowing down to one topic, but like per story. But whether the whole class pursues the same topic or whether I mean, the whole class, like, let's say mental health is what everyone is interested in. The whole class could decide, let's put together one single story and, work on that. Another option would be everyone's interested in mental health and you all want to do different aspects of mental health. We could do that too. Or you could divide into groups. It's quite flexible. It's really, whatever you all are most interested in, how the interests kind of divide across students. Also, half of you could decide to work on mental health. Another, one student could decide to work on lead. Another student could decide, I'm most interested in like dental health. That's totally fine. So,
And I
Alex
have
is
another
interested
question.
in dental health. Yeah.
I just wonder, like, what kind of data will we have? Will we have the raw data like we had like in CSV file, or like will we have like because they presented us some like already made graphs from the website. So I just don't know what kind of data will we have for this assignment.
Yeah, so it's worth so maybe something that would be worth us all doing before Monday's class is to take a look at the data set they shared. So I posted a link in Slack, and then there's also a link in the assignment for like kind of README file, the Vermont Department of Health data portal. So that, from digging around myself, it looks like it's like some statistics are broken down by county, some are broken down by the whole state, and it's only Vermont, so it's just one state. And then it's basically like counts of things, and that could be sometimes broken down by demographic, although not for most of the data kind of types or sources or categories, I guess. But there's like stuff on cancer and obesity and like food, access to food and housing and that sort of thing. Those are, as far as I can tell, all in like Excel spreadsheet format. And then it sounds like from that, like Rudy had showed a slide with like suggested sources for looking at other questions. So I hadn't seen those before, but I'm guessing, those are things that could be Googled, and we could just look into what's at those sources if there's anything useful. So that might take some digging on our end beyond what has been shared with us already. I'm also thinking, just based on today's discussion, like we'll probably end up combining multiple data sources. So one data source might have like how many people report suffering from any mental health, issue that, like, according to self-report. So that might be one table. Another data set might be like, for people who report mental health concerns, how are different, like, specific issues broken down across different people. That might be broken down by demographic or not. So we might have to like do some inferring of, like, we might not have all the numbers we want for every kind of dimension we want to explore. And that might involve making some inferences or guesses or combining across different data sources. And that's fine. It just might take some Googling. Yes, Allison, and then Fanmarie.
So what would you like us to do over the weekend and for Monday? And like, what should be the timeline for us going forward?
Yeah, so for Monday, it'd be great if you could all do some thinking about, continue to think about what sorts of questions you're interested in. So the like suggested focus areas would be mental health, lead, gender and sexual minority issues in schools, youth concerns or issues broadly construed. And then I guess school issues presumably involves youth also. So I guess that would be a subset. But then youth issues in general, and then oral and dental health was the last category that they specifically mentioned. So those would be maybe a place to start. So if one of those or one or more of those categories speaks to you, then I'd suggest taking a look at the Department of Health data. And then you could also look at the slide with all the suggested data sources and like look up some of those data sources and see if there might be something interesting there. And then on Monday, I'm thinking we'll, hopefully play around with some data sets, do some more brainstorming if needed, and start like, actually playing around with code and like loading the data sets in and putting it in the right format. Usually the first time we do that, it's gonna, there are usually some pain points there. And so we'll, work our way through that and get the data into a format that we can all actually use and make sense of, and that'll help with visualizing it and that sort of thing.
For the data, sorry, and then for already said this follow-up question. For the data sets, is it just the ones from the Department of Health website, or like I know they mentioned a lot of other sources? Do you have links for those, or do we have to Google for those?
I don't have links. Yeah, today is the first time I learned about those other sources. So, we can Google them. I'm happy to Google them, or if others find them, why don't we maybe post them in the like data sources and story ideas Slack channel, and then we'll all have them. Funri, did you have another question?
Yes, I just wonder because I'm quite interested in the question that I asked them, like about like other treatments are being delayed or kind of ignored because of the pandemic. Can I just dig into like this question? I will search online to see if I can find something during the weekend.
Sure. Yeah, that's great.
Thank you. And will we meet on Zoom or in person next week?
I'm guessing on Zoom, but I want to check the case numbers, and I'll send out an announcement on Canvas. They are going down, and so I'm trying. I also am like, I don't want to keep stringing you all along, so I'm trying to balance that. But I would like to move to in-person as soon as we're able. And so I want to see what the numbers look like, and then I'll talk with other faculty, see what they're thinking, and we'll go from there. But I'll send out an announcement by Canvas. All right, everyone. Have a great weekend, and thank you for a good discussion today, and I will see you all on Monday. Take care.